A big thanks to the Assistant Secretary for the presentation. My name's Mike Beebe. I'm the former governor of Arkansas, and together with my colleagues who you have either already heard from in the case of Governor Heineman or will hear from the other governors, we want to welcome you. Thank you for your attention and thank you for your input. This is a problem that affects the whole country, but some areas of the country, some geographic locations within specific states have a greater degree of problem than other areas of perhaps that same state. In my state alone, in 2016, there were 169 opioid-related overdose deaths. That's a rate of 5.9 deaths per 100,000 persons. Compared to the national average of 13.3 deaths per 100,000, that looks a lot better. Having said that, let me tell you where it doesn't look better. In 2013, our providers wrote 117.5 prescriptions for every 100 persons. And that same year, the average rate was for the rest of the country was 79.3. So while we did better on the actual number of overdose opioid deaths, we did much worse than the national average in terms of the excess providers prescriptions. On a bright note, though, opioid prescriptions actually declined in 2015, both on the national level and in my state of Arkansas. It declined about 5%. But so much more of this stuff needs to be done, as you've already heard, and that's why the BPC health team has focused on this and made this a priority throughout the course of the last year. Came up with recommendations. We sent those recommendations to the administration, as has already been pointed out. And I think Governor Christie was leading that group for the administration. And we had conversations back and forth that were productive, and they were very receptive to BPC's activities and recommendations. We actually focused on three areas. One, curb the supply of the opioids, both those prescribed and the illicit ones, such as heroin and fentanyl that have already been mentioned. Simultaneously, we need to increase the evidence-based treatment and support for recovery. You've heard the Assistant Secretary talk to some extent about that. You will have a panel discussion momentarily that will delve into it as well. But the growth in the supply of fentanyl, I asked the question a while ago, we've seen that reduction in first-time heroin users. Has there been a corresponding increase in first-time fentanyl users that actually replaces the heroin use? We all know that the fentanyl trafficking has picked up significantly, but the bipartisan legislation introduced in Congress that we talked about, that was acted on last night, at least in one house, acted on last night, is designed in some part to help interdict the supply of the deadly synthetic of fentanyl. We're pleased that the Interdict Act was previously signed by President Trump earlier this year. The rates for opioid prescribing are still way too high, even though there's a positive downward trend. But more can be done, and we call on the federal government to require every holder of a DEA controlled substance license to take a course in proper opioid prescribing. CDC data shows that some counties in the United States far exceed other counties in the rate of prescribing. As I mentioned earlier, and I think Governor Beshears can talk about this perhaps better than anybody, there are counties in the state where there's a huge over-prescribing, whereas in other counties in that same state, there seems to be less of a problem at all. So a lot of it's geographic and a lot of it's economic, and you'll probably hear discussions about that. We also suggested that we needed to promote access to treatment and recovery supports. We continue to urge the American public and policymakers to recognize that addiction is a disease that requires ongoing support, not just acute support. Providing people recovery supports such as housing, employment, and other services that are needed to sustain a person's personal recovery. And as you heard the Assistant Secretary say, we need to tackle the stigma head on. The stigma attached to people with addiction keeps too many people from that on-ramp that he was talking about, from seeking treatment. And it prevents families from coming forward actually when they need help. We call on the Commission to join with private sector organizations to mount a campaign against that stigma, to promote the expansion of syringe service programs, and lastly, Medicaid should take steps to ensure that pregnant women and newborns exposed to opioids get the care and the treatment that they need. These are the main elements of the letter that we sent to the administration and our recommendations on how to tackle the opioid epidemic. Address the supply, get the people the treatment that they need, and work to end the stigma against those with the disease of addiction. Many of our recommendations have been adopted, are in the process of being passed in the current legislation. Many are not. So it's an ongoing battle, something that we'll continue to fight. The BPC staff on this is to be commended. The governors appreciate the hard work that the staff, Doctor, we appreciate the hard work and leadership that you've provided, and we appreciate all of your interest here, because that heightens the awareness, which actually will infuse some people to action. With that said, I now want to talk about turning it over to a panel discussion, and my colleague Jim Douglas from Vermont, my colleague Steve Beshear from Kentucky, and then Regina LaBelle are going to be interacting, I suppose, with one another and with you all in a panel discussion. So if you all come forward, thank you very much.
Thank you, Governor, and thank you, everyone, for being here today to join us in this important discussion. As the Governor said, my name is Regina LaBelle. I'm currently a public policy consultant and a visiting fellow at the Duke Margolis Center for Health Policy. And I'm joined on this panel today by Governor Beshear from Kentucky and Governor Jim Douglas from Vermont, two states that have dealt with the opioid epidemic for a number of years, both during their term as well as after their time serving as governors. So what we're going to do today is have about 30 minutes for a conversation, and then we'll have about 15 minutes for an opportunity for questions from the audience. And I have a couple questions that I wanted to start with. First, I think to both of you is if you could tell us a little bit about how this epidemic first has affected your state. And tell us that one of the most important aspects of this issue is how it's really personally affected a lot of people, including governors. And if you could tell us a little bit about that from your perspective. So, Governor, if you want to start off.
Well, in Kentucky, which is one of the ground zeros for this issue, I came into office at the end of 2007. The Great Recession hit us right at that time. How fortunate I was to become governor right when that hit. But we all recall what happened. People lost their jobs. People were out of work. They couldn't find work. And I think despair built up, hopelessness in some areas built up, particularly in our rural areas, and we have a lot of rural area in Kentucky. Our coal industry turned bottom up in like 18 months to 2 years, and you had 15,000 people out of work almost overnight, and with no hope in their minds, at least, of being able to get a job that could support their families. And so it was that background, I think, that sort of caused, at least in Kentucky, a ballooning of this problem. I mean, the problem was there and it was building. I don't think we recognized it the way that it finally popped on the scene in like 2009, 10, 11. I mean, it just all at once, we were hit in the face with it. And I would tell you today, and it's something you know, this issue is no respecter of persons. It's no respecter of class. It affects every family from the most wealthy to the poorest in every section of your state, although it is, I think, more prevalent in our rural sections. And it is growing. I'm glad to see numbers that indicate we may be getting a handle on this to some extent, but I'm going to tell you, this is an epidemic of gigantic proportions in my mind. And we are yet, I think, on a national level to really recognize it for what it is with action items. I really applaud the Congress for doing what they did last night, but it's not enough. I mean, this piecemeal approach, you can't solve this every year. You know, back when HIV/AIDS hit us all back in the 80s, we finally, as a country, recognized that as a huge issue, and we invested 10 times the money that we're investing right now in the opioid crisis, and we finally sort of got a handle on it. And in my way of thinking, Regina, we've got to do that same thing with the opioid crisis, or we're just going to keep sort of spitting in the wind with every year doing smaller kinds of things.
Great. Thank you. Governor Douglas?
Well, I assumed office 5 years earlier than Governor Beshear did in Kentucky, and I could see the impact of the opioid crisis back then in the early part of the 2000s. It wasn't initially on my radar screen, but during my campaign in 2002, I encountered a lot of people around the state who told me stories about their own families and personal circumstances and how it had impacted their lives. I remember vividly chatting with one woman in the Burlington area who gave evidence to your point, Steve, that this is a classless problem. She said, "I'm a teacher, my husband's an engineer, and our daughter is dead." And so it really got my attention as I talked with more people around the state and saw the statistics of ER visits for opioid abuse rising, fatalities rising rapidly. And so when I assumed office in 2003, I launched a program I call DETER, everything needs an acronym, drug education, treatment, enforcement, and rehabilitation, to attack all of the aspects of the problem. We created a group in our state police called HEAT, the Heroin Enforcement Action Team, with greater resources to go after dealers. We increased the number of recovery centers from just one when I assumed office to more than a dozen by the time I left. We increased medication treatment options. We had one methadone clinic in Burlington when I assumed office. We now have several. We have buprenorphine treatment options, and we have a mobile methadone program because in a lot of our rural areas there's not enough critical mass to justify a fixed clinic, but still a tremendous need. And we put a counselor in every junior high school in the state, which maybe is too old an age group based on what I've been hearing more recently, but nonetheless to try to get some interaction with our young people. And I agree completely with my colleague that this is more of an issue in rural parts of our states and country. That perhaps was the most surprising aspect of it when I began to become involved. There's a report a year or so ago by a rural health center in Maine that confirms that trend as well, saying that in rural areas, young people in particular are more likely to become dependent on opioids. And there's an economic aspect to this as well. You mentioned the Great Recession that began when you took office, although I don't think there's any cause and effect there, Steve. But we're now facing a slight decline in our population. We're aging. We're one of the 3 oldest states by median age. Our workforce is shrinking. There are help wanted signs all over the place. And my message to Vermonters was that there's an economic imperative to deal with this because we need more workers. We need more people fulfilling the job opportunities that our entrepreneurs are creating. We need more taxpayers who can keep our governmental services going. And we're losing a lot of this potential to overdose and addiction. So we're making some progress. I can't tell you that in Vermont the trend line that we saw on the screen has leveled or declining, but the rate of increase of overdose deaths is not as steep as it was 10 or 15 years ago. So I think we're moving in the right direction, but this is a crisis that requires all hands on board to attack it from every angle.
Right, thank you. So since this is the Bipartisan Policy Center, I think it's important to address the bipartisan nature of this issue. And if there were ever an issue that cries out for a bipartisan response, it is this. And interestingly, you both you served a blue state and you served a red state. And so perhaps you could talk a little bit about the bipartisan nature of the issue.
Well, interestingly enough, in Kentucky, this was the issue that was the breakthrough issue in me pulling Democrats and Republicans together. When I came in, I was elected as a Democrat, and I had a Republican Senate and a Democratic House. And, while it certainly wasn't like it is in this town, where you can't even look each other in the eye for fear that someone will report you, it's down at the state level too now, just not quite as strong, but it's getting stronger all the time. So, we had some fits and starts in terms of trying to get things done. But this issue, when it really mushroomed, I came up, and of course it came first with pills, abusing prescription drugs. And I came up with a package of things to do. And I got the Republican leadership in the Senate as well as the Democratic leadership in the House together. And, it took me a while, but finally, one Monday morning during a session, the Republican leader of the Senate walked into my office and said, "I'm ready to go." And I said, "What changed your mind? Why are you ready to go?" And he said, "This weekend when I was home, everywhere I went, someone walked up to me, whether it was the post office, the drugstore, the restaurant, and said, 'You all have got to do something. I just lost my son. I just lost my husband. I just lost my aunt to an overdose.'" And that issue then helped me pull together the Republicans in the Senate, the Democrats in the House, and we passed some very stringent legislation in Kentucky. I mean, we basically ran the pill mills out of the state. We required all of the prescribers to use our electronic monitoring prescription system. And quite honestly, I proposed that. The Kentucky Medical Society went crazy on me and said, you're interfering with our practice. And I said, "Yep, I am. Where do you think these pills are coming from?" And so we forced that through. And then, once they got used to the system, it's fine. Because it takes 30 seconds to a minute to actually put the information in and see if the guy was around the corner yesterday at another doctor filling the same prescription. And we required more education of the prescribers. This is one of the biggest issues that we have, is simply, like the secretary said up here, I was taught in school that this was non-addictive. This was sold to these folks as non-addictive. And that's why we got a bunch of pharmaceutical companies in court right now. And I'm myself thankful for that, but because they need to be stepping up and helping us toward a solution to these problems. But we passed really a comprehensive set of bills, and it basically worked. I mean, you really saw things getting better. We knew it got better because heroin and fentanyl popped up. When you couldn't get the pills, people that wanted something went looking for something else. And all at once, we were faced with an entirely new issue, or at least an extension of the issue. And so then we had to come up with legislation to, we put Narcan in the hands of the first responders. We allowed needle exchanges in Kentucky. Can you imagine that? But we did. And we strengthened some criminal statutes on the big traffickers of fentanyl and heroin and that kind of thing. And again, tried to zero in on treatment and education. Where we still fall down, I mean, we can do all this stuff, but until we get our arms around treatment and take the stigma out of this and get people back on their feet and into society as productive members of society, we're never going to solve this. And that's a tough deal, because this isn't a 30-day deal. This is years of really wraparound treatment for people to get them back. So I mean, this problem's going to be with us a long time. But back to your question, I mean, it really opened up things on a bipartisan nature, and it helped me then on a lot of other things to do the same thing.
Great, thank
Yeah, if there's an issue that lends itself to bipartisanship, I think this is it. You're right, Regina, that you have to search high and low to find a Republican legislator in Vermont, but the last 11 governors. Yeah, right. But the last 11 governors have been of alternating parties. So each party knows that it's going to have this responsibility at some point. And I sensed a tremendous bipartisan commitment to dealing with it. I mentioned that my predecessor, who was a Democrat, opened the first methadone clinic, and then I expanded treatment options and preventive programs and enforcement efforts as well. A Democrat succeeded me. He increased spending on all of these areas during his tenure. Our current governor is a Republican, and he's continuing to move the ball down the field and addressing more aggressively the supply issue to which you referred. And we have a report recently from Blue Cross Blue Shield of Vermont that indicated that prescriptions dropped even more rapidly than what we saw on the screen, a 20% decline in just the last 6 months of 2017. So that's positive. The new governor also Governor Scott initiated a drug take-back program by deploying all of our state police barracks to accept without questions asked, prescription drugs, and incredibly, I asked for some information from his staff, and I had to call back and ask if it was true. But in Vermont, since this program began last year, 9 tons of prescription drugs have been deposited at our state police barracks in our little state. So it's a very serious problem, and I think that's got to be a key element of our strategy going forward. But as in Kentucky, that bipartisanship on the opioid crisis led to other cooperative efforts. 2 years later, we passed a comprehensive health reform measure. Few fits and starts, but in the end, we got a major package through that reduced our uninsured rate by 1/4 and began to bend the cost curve. We put all of our Medicaid folks in managed care, and I think are making some real progress on health care reform in a broader sense.
Thanks. So in looking around the corner, in our last question to you both, do you think the epidemic has peaked, and what is around the corner? What are we looking ahead? Because addiction obviously doesn't. If we solve the opioid epidemic, we're not necessarily going to solve the addiction epidemic. What's around the corner?
Unfortunately, I think more of the same unless we really get serious about this. And I know we're all serious about it, and I know these folks up here are serious about it. But, you know, we've got to put our money where our mouth is. We've got to make a commitment at the national level in this country to tackle this thing and get a handle on it. Otherwise, doing this stuff every year, you know, and what they do is good. I mean, I don't have any problem with that, but you cannot get your arms around this issue in fits and starts because it's going to outrun us. I mean, these folks that manufacture this stuff come up with a new one every 15 minutes. They can, you know, we can get control of this and they'll come up with something else. So we have really got to tackle this on a nationwide basis and have that commitment to do it. We've proven we can do it. We did it with HIV/AIDS. And obviously it's not gone, but at least, you know, we're managing that. And we can do it this way. Obviously, we've got to, you know, as the economy improves, hopefully it takes some of the hopelessness and the reasons away from doing this. But we're so far down the road now in the usage. You know, you can't go into a room anymore. And I could do this in this room, and I feel safe that if I said, you know, anybody who doesn't know someone or have someone in their family or have a friend down the street that has a drug problem, raise your hand, and I probably wouldn't get a hand raised because, I mean, it's everywhere. And we've got to understand that, and we've got to commit ourselves to the fact that it's a disease. We've got to treat it as such. And as much as anything, if we could come up and I know research is being done on this, if we could come up with new pain medications that are non-opioid based, you know, what a wonderful thing that would be. Quite honestly, we need to come up with the idea back in our minds that we're not going to be pain-free. You know, I mean, you know, everybody's got some pain. It proves to me I'm alive every day. And you know, we shouldn't be thinking that our lives ought to be pain-free. I mean, there is chronic pain. I fortunately never had it, I guess, but so many of the people out here think, oh my gosh, I got a pain, I ought to be able to take something and not have it. And you know, we got to get away from that. We got to get back to the idea that pain management is for the very, very ill people, for the chronic pain that is end up connected to something's going to kill you. You know, there's got to be some recognition that we can't treat every pain that we have.
You're exactly right. On that last point, Admiral Giroir mentioned that there are other approaches in dentistry, a little more anesthetic when you have an extraction or some other serious dental work, physical therapy, other kinds of interventions that ought to be used before you pop a pill. And I hope that will be part of the mentality that we have in the prescribing community going forward. You asked, has it peaked? And as I said, in Vermont, the rate of increase of the problem has begun to subside. So I guess that means we're not quite at a peak, but we're getting closer to it. But we have to continue an all hands-on approach at the federal and state levels. And as Steve suggested, we're grateful for the steps that have been taken in Washington, although they're not as many as we need. The President's declaration of a public health emergency, the appointment of the commission last year, the legislation that's moving forward are good positive steps. But we can't let our guard down because of the severity of this crisis. So I think we can make some greater progress at the federal level through interdiction. I'm from a state on an international border, and there are a lot of shipments that are caught coming from Canada, but that leads me to assume there are a lot that are not. We've got a few Vermonters serving a long stretch in a federal institution now because they thought they had a clever idea. You may be familiar with our geography. Lake Champlain is a large body of water that transcends the international border, and they decided to float some drugs in little containers down the lake one night, but they were caught. That's a role that the federal government can play, and through the Postal Service and Customs Enforcement, I think that would be very helpful. But we've got to address the other aspects of this crisis, as states are doing, and we again would ask the feds for maximum flexibility because states are different, priorities vary, and one size doesn't fit all.
Great, thank you. So we are open to taking questions from the floor. If actually, I think we'll start in the back. So, thanks.
Hi, my name is Cosette, and I'm a fellow at AMFAR, the Foundation for AIDS Research. And my question is, there have been several studies recently published that demonstrate that Medicaid expansion states have had a significantly higher uptake of medication-assisted therapy that is compared to non-expansion states. And I was wondering how you feel that current attempts to limit Medicaid expansion, most notably Kentucky's proposed work requirements, the impact that will have on these efforts to kind of round the corner on the epidemic. Thank you.
Well, of course, I was the culprit that expanded Medicaid in Kentucky, and I'm proud of it. You know, we instituted the ACA and fully and expanded Medicaid in a state where President Obama had a 30% approval rating. So I had to call it something else. but you know, one of the great things about the ACA were those 10 essential benefits that were set out that had to be covered, whether it's in the Medicaid program or in insurance policies, and one of them is drug treatment. and behavioral health treatment. And I think because of that, we saw a lot more of our folks almost immediately getting treatment for drug abuse. And obviously, who can argue with that? I hope nobody can. The next administration that came in decided to apply for a waiver to try to put work requirements in, and wanted to basically eliminate or severely limit dental and vision care. You know, two areas. You know, so much of our health system ought to be geared toward prevention and early detection. And two of the things that give us as much early detection as anything of chronic disease is vision care and dental care. I mean, everybody will tell you that, boy, they can tell a lot about what's going on in your body as they take care of your teeth or as they take care of your eyes. As you know, that was approved by the administration. It was stopped by court action. It is back again in front of the administration. I think if you read that court case, I hope I know what's going to happen to it if it comes out again, because right in the you know, the regs on waivers and the definition of a waiver is basically an experimental idea that's going to improve whatever you're working on and make it better. And, you know, in the application it says, you know, we're going to throw 90,000 people off of health care within the next 2 years if this is approved. And I keep thinking, how is that, you know, improving health care in our state? But you know, that's going on, and I hope that it's rejected too. You know, the last word was, if it's rejected, we'll just do away with expanded Medicaid. And with an election coming up, I want to see that happen. Right. So it's been a real boon to Kentucky, a state that, when you look at our health statistics, my God, we're at the bottom in everything. I mean, you name a chronic disease or condition, and we're either. He's close behind, but no. But you know, 48th, 49th, and this, that, and the other. And if there's any place that needs good quality health care for everybody, to not only improve their quality of life, but to improve our workforce. I mean, you can argue this in economic terms as easily as you can argue it in moral terms. And you know, if you want to attract more jobs, more productive jobs, more companies to come into your state, then you need a workforce that can do the job. And if you're home sick every other day, or your kid's home and you can't go because you're home taking care of your kid, you're not going to have a productive workforce. And so you're not going to attract that kind of economy. So it's a no-brainer, you know, in a place like Kentucky.
Just for the record, we expanded Medicaid before the ACA ever came along. In 2006, specifically, we went up to 300% of the poverty level with a state subsidy that was based on a sliding scale. And so we've always had the second or third lowest uninsured rate in the country, of which we're proud. But to your point, more people on Medicaid means more access to providers and prescribers and more prescriptions, and so we do have to be vigilant about that, and that's why controlling prescriptions is even arguably more important than in expansion states, because there may be more prescribed and dispensed. So it's something to keep an eye on, but we're still proud of the fact that we have a lot of coverage for people in a state that's either number 1 or 2 in the health rankings on an annual basis.
Thanks. Yes, actually, let's go to someone who hasn't asked a question before. Go ahead.
Michael Cook. I'm both a healthcare lawyer for about 40 years in and out of government, and also on the Medicaid board in Virginia. I have a specific question.
Bless your heart. You're in Virginia.
We
You've
finally
got some work
got
to do now.
We finally got it. Yeah,
Yep.
It's great to have that work.
Yeah.
Although we have a corollary issue ourselves. But I was down in Wise County this year at the free clinic, and one of the things that just smacked me in the head, even though we all knew it, was talking to people who walked in there, were adults having God knows how many teeth pulled that afternoon, and the pain that they had there. And we're sort of struggling with, a couple of us are struggling with, how do we make the case for adult dental care and Medicaid? And is there a way to tie the opioid addiction into that with the pain that precedes the absence of care? And you guys have been in rural areas.
Yeah. Certainly, we heard the Secretary say that the Dental Association has taken a real aggressive approach about prescriptions, because there's no question that a large part of the people out here today that are addicted started on pills. They may now be on heroin and fentanyl, but they started on pills. And where did they get those pills? Now, a lot of them from the doctors, and we're trying to educate them, and I say doctors including dentists and the whole professional structure. And we're now, I think they are now recognizing that they're part of the problem. And you know, they didn't for a long time. And now they are. But the dental care that a person gets is a part of a spectrum of services that they need that affects their health. I mean, there are so many things that you can end up with because of something that goes wrong in your mouth. And you can die from a lot of things that will develop because you didn't take care of something in your dental part. And so I'd bring them down and let them just see these people. I mean, as you say, I mean, we have lots of people who have no teeth because, you know, as kids, they had no care. They grew up with no care. And by now, you know, the only thing that you can do is go in there and take out all their teeth and get them a set of dentures and that kind of thing. And that's, you know, it's time to just look and recognize that we can solve a lot of the issues we have rather inexpensively if we back up and do it on the front end. Instead of treating on the back end, if we prevent on the front end, we can not only bend that cost curve, but we can create a society that is much healthier and a much more productive society in every way.
My wife was a dental assistant for 39 years, so I brush and floss regularly, but she often made a lot of these points as to the impact of dental care on other health indicators and how important it is to everybody. And I remember seeing a survey, it's been a while, 10 or a dozen years ago, of welfare recipients, and they said their greatest health concern was dental care. It superseded anything else because, well, for several reasons: the practicality, the pain, the image, and ultimately their employability they felt was impacted by it. So it's very important. And I guess lacking a silver bullet, I would agree with my colleague that we have to start early. And we've got several schools in Vermont with dental clinics on site, and if we can instill in the next generation a sense of urgency of good dental care and oral health habits, then I think in the long run we'll get where we need to be. But I'll be honest, we started a very extensive program of dental care back in the mid-aughts, but when the Great Recession hit, we curtailed it a little, just out of a sense of reality. So I think focusing on young people probably is the long-term best strategy.
Thanks. We have time for one more question. We'll go in the back.
Hi, my name is Krishna Patel. I'm from HCM Consulting. I'm a health policy and advocacy intern. I had a question regarding the ties with opioid abuse. Would you please extend your remarks on the lack of access to care within rural areas, telehealth access regulations, and its tie with overall mental health?
Well, those states, and I think every state has this to some extent, which any state that has a rural area ends up with with issues that are somewhat different than in your urban areas, and in many times more concentrated. It's a combined lack of work, lack of jobs, lack of education, because education maybe is not as quality in those areas as it is other places. But you end up with unique problems in your rural areas. When we instituted the ACA and put in expanded Medicaid, the best example I can give you, you get these stories of, well, these people, they ought to want to take care of themselves. When we flipped the switch and crossed our fingers and said a prayer that our exchange would work, and it did, I mean, in the first 18 months, we signed up 500,000 Kentuckians who wanted health care. I mean, that told me something just in and of itself, is that there was such a pent-up demand and desire for being able to take my kids, going and seeing about this spot on my face that may be skin cancer, but I can't afford it. And I mean, boom, in 18 months, it just mushroomed. And our uninsured rate went from over 20% to 7% in 18 months. Now, the providers weren't left out either, because our uncompensated care rate went from about 25% to less than 5% in 2 years. They kind of like that. They weren't getting maybe paid what they felt like they should, but they were getting paid something. Now, our rural hospitals, because of what we did, we're in the black for the first time ever, and not just worried about, oh, we got to close tomorrow because, I'm not sure we can keep our doors open anymore. So the whole idea of providing health care for more people has so many ripples out there that it affects positively. Your rural hospitals are not only necessary for the health of your people, but it's an economic driver in your rural communities, and it's an elevation of education. It's just an elevation of quality of life in your rural communities, and to encourage that and to enhance it is going to give you a lot of improvement in every way, not just health, but economically and I think in general quality of life.
The main study that I mentioned earlier, I wish I could cite the specifics, said that someone in a rural area who is young, male, unemployed, unmarried, without a high school degree is far more likely to become addicted than someone else. And the unemployment rate is generally higher in the rural parts of our state. I think that's true in Kentucky as well. So there is a fairly logical connection between the rural nature of a part of our country and the a greater likelihood of becoming addicted. So that, as I say, was one of the biggest eye-openers to me. I just assumed it would be an urban problem principally, but it's even greater in the rural parts of our state, and so I made sure that we focused on that. One part of the bill that I understand was approved last night is a requirement for e-prescribing, which is good as long as there's a connection in remote rural crannies of our. Well, yes, exactly. So I hope that doesn't create any problem. But we have to focus on the rural parts of our country because statistically, that's where a problem is more likely to occur.
Great. So thank you to Governors Beshear and Douglas, and if we could just give them a hand. And we'll now turn this over to Governor Gregoire.
Well, good morning. I'm Chris Gregoire, former governor from the great state of Washington. I want to thank each and every one of you for coming today, for your engagement, your interest, your passion for the issue. And I want to give a special thanks to our Assistant Secretary Giroir for his remarks today and his fine work at HHS, and also for our panelists. Thank you all for being here and for what you're doing today. If we were to take away one thing from the discussion today, I hope that one thing is this is a bipartisan problem requiring a bipartisan solution to move forward. And the congressional efforts to date have been exactly that. And I want to say thank you to those who've been engaged and been involved to make that happen. And I want to give a particular shout out, if I can, for our senator from the state of Washington, Patty Murray, who has worked tirelessly with her colleague, Senator Lamar Alexander, to produce the bipartisan Senate bill that was then the genesis for what was the bipartisan bill, conference bill that went out last night. And they, of course, were on that and helped make that possible as well. This legislation provides for treatment expansion and support for recovery, including funding for HHS to give grants to the states, and flexibility, as the Assistant Secretary said, because there's not a governor in the country who won't tell you we are not cookie cutters. We don't all look or have or act the same, and therefore we need the flexibility to be able to address the problems that we have in a manner that we think will be most effective. The conference bill increases education and awareness to improve prescribing practices, to bring down unnecessary opioid prescribing, and it increases coordination and capacity of our federal agencies, and importantly, the Postal Service to interdict fentanyl trafficking. Much of what is in that bill we supported. There are things that we supported. Our doc has been very helpful here at BPC in helping us with that, are not in that. So again, my message to you today is thanks for all you've done, thanks for what you're doing, and don't ever stop what you're doing. This has just begun. This piece of legislation, I want to applaud what they've done, but I want to be clear, it's just a beginning. It's going to take a whole lot more by all of us. And the Bipartisan Policy Council is here to continue to make sure that is possible. So again, thanks for coming today and have a great one.